Supportive personnel have a great ability to connect with patients and peers. And if that's utilized effectively, it will make a great place to work with, great people to work with, because utilizing the supportive personnel and the great connections that they have. I feel like assistive personnel are kind of like a lot of times the middle piece, and we don't utilize it in that way.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Danielle Anderson, Research Assistant at the University of North Carolina Medical Center in Chapel Hill, about the role of supportive personnel in improving quality and patient care in oncology. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome, and thanks so much for joining us today, Danielle.
Thank you.
We know that cancer care teams are comprised of staff from a variety of backgrounds, and they each contribute specialized knowledge and skills to achieve the best patient outcomes that we can. So to start off, let's talk a little bit about your education and career. What is your educational background, and how did you come to work in the world of oncology?
I have been a nursing assistant for going on 17 years now, and then recently a research assistant for about 1.5 years. I came into oncology. I started off working at a GYN oncology clinic at UNC Hospital. And in my clinic, I started picking up shifts on the inpatient floor kind of through word of mouth on a hematology oncology unit. And the more shifts I picked up on the unit, I began to enjoy working on the unit. And I decided that I wanted to go back to school kind of part-time. And working on the unit was a little bit more flexible with scheduling versus my clinic. I enjoyed the patients on the unit, my coworkers, and I just ended up transferring to the unit. And I have been there now a little over 11 years.
Wonderful. Well, that's just a great journey. And it seems to be, in my experience, that once people finally get into oncology and they kind of understand what it is and they get past sometimes the fear or the just not sure what it's all about, like, you'll never leave. You're stuck with us now. So it's so great to hear how your journey brought you through different environments, but really helped you kind of recognize that you enjoyed that population. So at the 2024 ONS Congress, you presented a poster about a project that you did at UNC involving assistive personnel supporting quality improvement initiatives. Can you describe why that project was initiated and what were the initial goals?
So the project was initiated for several reasons. I worked on a 53-bed oncology unit that had limited staff and resources to complete audits on things like central lines, Foleys, tubings, turn compliance, falls, different things like that. Our nurses were dealing with high patient acuity and task overload. So one of our amazing CN4s came up with this awesome role as a cost-effective way to perform and sustain quality improvements on our unit. So the goals of this role was to improve patient outcomes, provide targeted compliance data collection, and to correct things in real time when possible, such as dressing changes, Foley care, and any other tasks that were within the scope of practice.
That's so interesting. I can't wait to hear more. Yeah, I think you just bring up already and just describing the need of recognizing that there is so much to get done, and it's a team sport. Caring for patients and their families, it takes all of us to do it. And so I'm excited to hear how you and your team recognize the ability to involve unlicensed personnel and assistive personnel to help support the work that nurses are doing and ultimately the care that patients receive. So what methods did you use in designing this project?
We started off with, we continue to do daily rounding on our patients. So daily rounding includes, we have patients with central lines, Foleys, just whatever it pertains each patient. So like I said, we were a 53-bed unit. So each patient was tailored to something different. So whatever rounding needed to be done on that patient, we did daily rounding on those things. Direct patient care tasks. So with me being an assistive personnel, I am an NA2. So there were tasks that I could do while I was in the room if the task wasn't done. So if the patient had an indwelling catheter, I could do Foley care. Patients with central lines, we do the CHG treatment. So that's something that I could do while I was in the patient's rooms doing my daily rounding, doing things like patient education on topics like the CHG wipes. And then also, too, one of the big main things is performing audits on central lines, tubings, CHG treatment, oral care, any measures that were relevant to the patient, any measures that were relevant to getting data. We were able to do those as well.
That's really interesting and really just highlights the importance of everyone on the team performing to the top of their scope and what is within the bounds of what they're able to do based on whether it's legal regulation for licensed personnel, hospital policy and guidelines and what you've been trained to do. And so it's a great example of how when we think about all the team members that help care for a patient, understanding how fully involved and complementary our work can be to each other when we take the time to really understand what the needs are and find out who can help, who can do the work.
Absolutely.
So, what are some of the outcomes of the project and how did you measure that success? Were there any sort of long-term changes that came from the project?
Some of our outcomes included within the first 6 months, years of starting this initiative, we had a significant reduce in hospital acquired infections. We had a really big increase in our audit compliance and improvements with all of our data collections. We measured our successes using infection control data from our infection prevention team. We had manual central line and Foley audits that were already part of our unit standard work that we were just able to comply with and look at, along with manual collection of the number of check me out signs. And that's one of the things when I presented at the ONS is a really big part of the project are the check me out signs. And pretty much these are the signs that I use to communicate with our nurses. And it's a simple sign that goes outside of the door for a task that may need to be done. So if I see that a central line is peeling or bleeding or needed to be changed, I use the signage outside the door as a way to communicate with the nurse saying, hey, this task needs to be done. And the part of the project was that either the task got done on that shift or the nurse passed it along to the next shift, but with the expectation that the task was done within a reasonable time frame. We also utilized safe reports, our turn compliance, which was electronic pull, oral care, and falls compliance, which was another electronic pull. So most of our data that we collected was all something that could be pulled electronically. And then I would think that like changes from this project, we had a really big increase in nursing care compliance with a positive impact on all of our quality metrics that we were measuring. Also having this accurate data in real time allowed management to target educational opportunities and interventions for our unit.
That's really amazing. Just to hear again, in the big scheme of things, a relatively simple sort of shift of who can do what and how do we incorporate that into someone else's role who maybe is, like you said, already in there doing work that would be part of your role already, and then just adding things that fit into that same touch point with patients. And then hearing just the significant improvements and changes that made for the unit, yes, for the nurses and the unit, but for the patients, right? The patients is what it's all about. So how exciting. I'm so glad that you were able to share that with us at Congress. What a great project. Let's shift gears a little bit and talk about just more generally about our supportive personnel that we have as part of our team in cancer care. What roles do you see supportive personnel playing in oncology?
I think supportive personnel play a major role in oncology. I like to think that we are the eyes and ears of our patients. We sometimes are the first ones to see when conditions change. We often provide like comfort and support while assisting with the many different tasks that we help with our oncology patients with improving the quality of life for our patients who are facing the challenges of having this diagnosis. So I think that we play a really big role, working alongside with nurses and physicians and PT and OT teams. I think we are kind of like the right hand to all of the teams that play a major part in our patients and in cancer care.
Absolutely. I think you nailed it. You explained those roles. I mean, I also consider when you think of anyone that is in with that patient, spends time in that patient's room, our environmental services personnel, our dietary staff that maybe help deliver trays on the inpatient unit. In the ambulatory space, those that are helping it with registration and check-in, even, of course, our medical assistants that are helping maybe to room patients and help with patient flow. Everyone plays a part. Everyone sees that patient. And as you mentioned, you have an opportunity to kind of assess how they're doing, what their needs are, and then being able to communicate that to the broader care team to make sure that their needs are met. What an important role for all of us to serve.
Yeah, absolutely.
How do you see supportive personnel contributing to quality improvement projects in healthcare organizations like you've done?
I feel like coming into this role has opened up my eyes to something that I never even knew that an assistive personnel or supportive personnel could even do. And so that just makes me say that there's so many things that we can do. And even on my unit, I'm constantly encouraging our assistive personnel through things like making safe reports, reporting incidents and safety concerns, which can give us good data for quality improvement projects, assisting with identifying areas for improvement, participating in unit or hospital wide committees, and bringing perspectives and ideas to the table that can ultimately help our unit, which can in turn help our patients and their care partners or whoever it may be. So I think assisted personnel could contribute like very highly if utilized in the correct way with projects in healthcare organizations.
Let's explore that a little bit more. So, what could you see, like certain committees or other collaborations or internal work within healthcare organizations? How do you see support personnel fitting into that?
Oh, yeah, absolutely. Once again, even before this role, I never thought about being on a committee. I never even knew that assistant personnel could even be on committees. I thought committees were tailored more towards nursing. But being in this committee, I feel like involving assistant personnel in committees can, number one, empower them and boost their morale, which in turn can have higher job satisfaction, good retention. In this role, I joined our infection control team. I'm on the falls committee, the housewife skin team, and many other committees that I've been on. I was the chair of what our hospital has. It's called APCAT, and it stands for Assisted Personnel Career Advancement Team. And it's a team that focuses on supporting and promoting the professional growth and development of our assisted personnel. So I feel like there are so many avenues that assisted personnel have. And when I go to these meetings, when I'm in the infection prevention team, when I'm with the falls committee, I'm able to bring things from the assisted personnel point of view to the table that sometimes nurses or higher ups may not have knowledge of because they're not looking at it from the unassisted personnel standpoint. And I think that is an awesome thing because we bring that hands-on experience because we are the ones who, number one, work firsthand with the patients, but we also work side by side with doctors and nurses and other health professionals. So I think there's so many avenues for committees to be open to letting assisted personnel come in and join and being part of their teams.
I love that. I love that. Serving as an advocate for your own teammates, the others that are in your same role, being an advocate for what they can bring to those committees and other committees as well. I love that. It recognizes that everyone, especially in healthcare, in service oriented roles, especially in healthcare and even more so in oncology, I think everyone who works in this field, we want to do something meaningful, help patients in whatever way we can. And I think you've given some great examples of how creating those opportunities for everyone who's part of the team to participate and collaborate and contribute in ways that bring them meaning in the work that they're doing. And ultimately that meaning translates down to impact to the patient. So this is just really great to hear. Tell me a little bit about some of the nurses that you've worked with that maybe have mentored you through your career path. How do you think oncology nurses can be that mentor and that support for the supportive personnel that they work with or other non-nurses to help them advance their careers and recognize opportunities that they could become more involved with?
There was many nurses who helped mentor. One of our CN4s, like I said, is the one who came up with this project. Her name is Jan. First, she's not on our unit anymore, but she was amazing. And it was amazing for her to see in me. First of all, I had been there a couple of years. So she was like, "Oh, you're so amazing with the patients." And she introduced this idea to me and asked me would this be something that I would be interested in. And I was like, "Oh, yeah, absolutely." So just with her even opening that door, and once she opened that door, the part of opening the door was for it to be open to all assistive personnel throughout the hospital. So not just starting with our unit, but making this be an opportunity for other assistive personnel to grow within their units. So her and my managers all at the time were all a big part of this project. They were super supportive and mentoring for this to actually become a position within the hospital. So that was a really, really big part of this, to give assistive personnel the opportunity to grow and not just be kind of stuck in one position, but have a way to grow into something more. So I would say that mentoring assistive personnel, offering training sessions on oncology specific topics, I think is very major, because if we're working with these oncology patients, it's vital that we know like the terms and what these certain labs mean, and when patients are neutropenic, or when patients, all these things are vital for assistive personnel to know, because like I said, we're the ones that's kind of right hand with these patients. So once we know, we can kind of have more in-depth ideas of when things are going wrong. I think encouraging assistive personnel and participating in continuing education programs that may be offered to learn more about oncology specific care, teaching clinical skills that may be within the scope of practice. With this position, I am able to do a lot of tasks that are beneficial to both our nurses and assisted personnel. So it takes a lot of the load off of them throughout the workday, which is super helpful. Like even just down to, we use what we call the Curos caps on our tubing. So if I go in a room and the Curos caps are missing, me being an N82, instead of me going and finding the nurse and saying, hey, there's something, I can just grab the caps and put them on the line. And so that's helping out our patient, that's helping out the nurse, that's helping out my team. So just little things like that. I think opportunities to shadow with nurses during procedures can kind of give us like that hands-on learning experience to know more about specific things that are going on and what to monitor with patients. And then also it just will help build connections within our healthcare team and your workplace and your unit.
All of that, just absolutely. I agree 100%. I'm just over here smiling and cheering as I'm listening to you talk. It really just, I think many nurses, I'm sure, who are listening are recognize some of the challenges that we are dealing with staffing, with having nurses, having enough nurses. How do we do the work without enough nurses? And really, since COVID, I think considering, is there a different way we can do the work with a different model of care, with a different team makeup of a team members? And so I think you've just given us a great example of how it can be done and how it's so important that we do it, because staffing aside, I think you've just really shown how everyone deserves to have those opportunities to learn and to grow and to be mobile and move through their career in ways that they find satisfying. And so thank you again. Thank you for sharing the experience that you've had. And I hope that our listeners hear this and are inspired to consider how they might be able to implement something similar at their own place of care. So what are your plans for the future, Danielle? Where are you headed based on kind of where you are now and what experiences you've had? What comes next for you?
The cool thing is that I think this, when we talked about ways of, how can nurses support and encourage it, it actually been in this role. I enrolled back in school. I've taken pre-nursing classes. I actually just graduated in May with associate's degree for clinical in science with my background in clinical research. So that opened up a little more avenues for me. I will be applying for nursing school coming up after the fall semester. So yeah, I'm excited.
That's so exciting to hear. What a great accomplishment. You should be proud of yourself for everything you've done so far. And it sounds like you've still got big plans on the horizon. So congratulations to you for that. Well, Danielle, thank you so much for what you've shared today. Just great perspective and ways for us as nurses to think differently about the care we provide and the team we work with and how we can bring everyone into the work in the ways that is meaningful and appropriate. And I think you've given us great ideas of how we can maybe consider how we change the work we do at our own places of care. As we reach the end of our episode today, we do like to always run through a series of quick questions just to help summarize some of the things that we've talked about. So to start that off, how do you think healthcare professionals can evaluate their hidden or implicit bias about working with supportive personnel?
I think number one is encouraging open communication and collaboration with your assistant personnel. We work together 8 to 12 hours a lot of times. So it should be second nature to talk and work collectively to take care of our patients. So like I said, even little things, even little tasks, it should be very much team oriented and super supportive, because without that, then it will always be a clash. And then I think take in and consider like individual strengths and contributions that assistive personnel can bring to the table. We are all differently and we all work differently, but if we take the strengths of one another, it just will make a better positive impact on our patients and the units that we work on.
What are some common misconceptions about the role supportive personnel play in healthcare?
One big misconception is the limited scope of practice. I think sometimes individuals don't realize how much your assistive personnel can do. It's more than just getting vitals, giving baths, things like that. Like I said, when I'm in rooms looking at lines, putting Curo caps on lines, our NAs can prime tubing. There's so many different things that can be utilized. And there's value in those things that can be done if you utilize these skills, because it gives value to your assistive personnel, but it also helps offset some of the tasks that nurses may be overloaded with. And then I think another misconception is, I think sometimes the misconception of the lack of expertise of knowledge. I work alongside brilliant assistive personnel who know the ins and outs of our patients, their care, policies, procedures, dynamics of the healthcare system. So I think that kind of is a misconception too, that supportive staff don't know like the ins and outs. And a lot of times we are so knowledgeable in a lot of things that goes on in the units.
What's something about this topic that's not often discussed, but you wish people knew more about?
I would say supportive personnel have a great ability to connect with patients and peers. And if that's utilized effectively, it will make a great, 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 great place to work with, great people to work with. So just utilizing the supportive personnel and the great connections that they have. I feel like assistive personnel are kind of like a lot of times the middle piece, and we don't utilize it in that way. So I think that's something that is not often discussed and people should know more about. Like I said before, some of the skills that we can do and some of the things that we can handle, even just down to some of the committees that we can be a part of. I think that should be explored. Like, sending an assistive personnel to be on the fall committee or the skin committee will bring great value to your team.
What additional training or education do we as oncology nurses need to stay current on understanding how we can involve supportive personnel in our care?
I don't think any necessarily training, but I definitely think maybe a better understanding of what the supportive personnel can do. So that way we can start to utilize that more in the workplace. Number one, for the nurses, point of view for them to be able to offload some of the things that they're doing, but also too, to give the assistive personnel more things to do within the scope of their practice, because sometimes we lose skill sets because it's something that we never do or never asked to do or never shown how to do. So I think that is a big factor that would be beneficial.
And are there any additional resources for maybe patients or other healthcare providers who want to learn more about assistant personnel and how they can be integrated into the care team?
I don't think there are any additional resources. I think we are pretty integrated in the team. I just think that we just have to take those skill sets and use them wisely.
Wonderful. Well, Danielle, thank you again for your time today, sharing your wonderful project, the outcomes of that project, and I think serving as a source of inspiration for all of our listeners to consider how they can look at their own care team and really help elevate the importance and the value of their assistant personnel that are helping care for their patients right alongside them. Thank you, Danielle.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.